Yeah, like please.
A very good evening to all of you. It gives me an immense pleasure to welcome all the distinguished faculty members, colleagues, postgraduates, and delegates for today's webinar, Demystifying Strabismus. So, strabismus, as all we know, is far more than just a ocular alignment disorder because it influences binocular vision, visual development, psychological well-being, quality of life, and long-term functional outcomes. Despite major advances in diagnostic, imaging, orthoptic assessment, and surgical techniques, strabismus often remains an area surrounded by hesitation and misconceptions. So today's CME has been thoughtfully designed to simplify concepts, bridge the gaps between the theory practice, and also for a insight into the contemporary evaluation and management of strabismus across all the age groups. So I sincerely thank all of you, and I encourage all the delegates to participate and hope that this will be a very enriching and productive session. So with that, I welcome both the national faculties, Professor Pradeep Sharma and Dr. Sumita Agarkar, for this session. So let me introduce them. So Professor Pradeep Sharma, sir, is the ex-professor RP Center and who is now the director of Strabismus Pediatric Ophthalmology and Neuro-Ophthalmology at Center of Sight, AIIMS, New Delhi. Sir did his MS and his MBBS from AIIMS, New Delhi, and he is a fellow of National Academy of Medical Sciences. He did his fellowship in pediatric ophthalmology and strabismus at Jules Stein Eye Institute, UCL. Also had in Wills Eye Hospital, Philadelphia. He is a recipient of lot of awards, some being the recipient of Richmond Award in International Strabismus Association in 2001. He is the first Asian to be invited to deliver the NAP lecture by the American Academy of Pediatric Ophthalmology and Strabismus at Vancouver in 2016. Sir has numerous publications, taught so many residents, and he's like our Bhishma Pitama. So welcome you, sir, to this session. And we are looking ahead for all our doubts to be cleared by you. We have Dr. Sumita Agarkar, who did her medical education at Indore Medical College, Madhya Pradesh. She did her fellowship in pediatric ophthalmology and strabismus from Arvind Eye Hospital, Madurai. And now she is the director of pediatric ophthalmology and strabismus at Shankar Nethralaya, Chennai. She has 55 publications, 10 book chapters, a very renowned pediatric ophthalmologist, and really love her as my colleague. So welcome you, Dr. Sumita. And now I hand over to the moderator, Dr. Devashmita Maji, to introduce our panelist, and Dr. Vivek, who is our own strabismologist with us, and then start the session. Over to you.
Thank you, Dr. Sucheta Parijaman. So let's welcome Dr. Vivek Warkar, who is our head of the pediatric department. He is a pediatric ophthalmologist, strabismologist, and neuro-ophthalmologist at LV Prasad Eye Institute, Bhubaneswar. It's more than a decade he is leading the department at Bhubaneswar, and his keen interest in complex strabismus, especially in craniostenosis, is really very much encouraging for all of us. So we are yet to hear from him today about esotropia. So along with Dr. Vivek, we have our own faculty, that is Dr. Shweta Dhimans. He is a pediatric ophthalmologist, strabismologist, and neuro-ophthalmologist from the Rotary Eye Hospital and the Research Center that is in Cuttack. And also we have joining Dr. Shrita Kiti Parida. So she is a pediatric ophthalmologist from the KIMS Hospital in Bhubaneswar. So as we have already started on time, let's start. We'll start our journey with Sumita ma'am. So Dr. Sumita ma'am, we request you to share few of the informations, new learning things about intermittent exotropia. To observe and when to operate. As already Sucheta ma'am has told that this is not only the cosmesis, it is about the binocular vision and the stereopsis. So the time is very critical, not only for the children, but also for the adults with intermittent exotropia. Over to you, ma'am.
Thank you so much, Dr. Devasmita and Dr. Sucheta, for giving me this opportunity. It's an honor for me to speak in this webinar alongside Vivek and Dr. Pradeep Sharma. So why should we talk about exotropia? Because it is far more prevalent in the Asian countries than esotropia. If you look at the Western literature, it always says it talks more about esotropia. But I think my experience is like everybody else on this panel, that we see far more exotropia than esotropia. It appears seemingly straightforward because it is exodeviation and children have often very good binocular function, and yet it is very frustrating to manage because undercorrections are very common, and sometimes despite you feel these children will do well and then they don't. There is diverse thought processes. There is more divergence about exotropia than anything else in the strabismus. And we still have a gap in knowledge about what exactly causes exotropia, why exactly normal, healthy, neurologically normal children drift. Don't have good answers on that. And we also don't know about the natural history and what is the best treatment modality for this. So there are still gaps in knowledge about these. So if you look at a textbook classification, you have a large group which is comitant, of which intermittent exotropia is most common, followed by infantile esotropia, and sometimes decompensated microtropias can also present like a comitant exotropia. Then there is secondary, which is could be sensory, secondary to any vision loss in childhood. I have put some reasons here, but they can be more than that. And then consecutive, which is post surgery for esotropia. Concomitant, again, restrictive, like Duane syndrome with exotropia, example, and paralytic. Very often we see it in association with oculomotor paresis. And then there is a group, pseudoexotropia, which doesn't fall into any of these classifications. So how do you define exotropia, intermittent exotropia? In simple words, it is defined as a large exophoria which no longer can be controlled by our own fusional and convergence mechanisms at all times. So there will be times when children are straight and then for no reason, like this child, as soon as you ask her to look at a distance target, she has a large left exotropia in the same sitting. Despite intermittent exotropia being very common, you can sometimes run across some children with other types of exotropia, like this child who has craniosynostosis and a V pattern and a large exotropia, which is fairly alternating. Another child here who has come to us with exotropia, and it turned out that he had a small cataract. He has myopia in the left eye and also is amblyopic. So you can see exotropia here, and that was the tip of the iceberg in this kid. You have this patient who came following surgery for esotropia at some other place. And as you can see, there is a large left exotropia, and you can see some surgery marks near inferior rectus, near medial rectus here, as well as here. And this will be a classical consecutive exotropia. This child, a congenital third nerve palsy, as you can see, he has ptosis, a large exotropia, and limited movements in almost abduction, adduction, elevation, and depression. This lady has a Duane syndrome with exotropia. Again, as you can see, they all present with exotropia, but etiology and management can be different. So this is post-FES, again, injury to medial rectus and a large exotropia with the medial rectus with the abduction. So this is one of those restrictive strabismus, which you can see. So my talk will be, even though I have shown you all these different types of exotropia, but my talk will basically deal with most of it. What we see in the clinic, 90% of our patients with exotropia do have intermittent exotropia. And workup of these children include visual acuity. We must definitely record visual acuity with any age appropriate chart. Even in the youngest children, it is possible. Sensory evaluation, because our finally goal, as Dr. Pradeep Sharma is so fond of saying, our goal for our entire job description is to achieve binocularity and maintain stereopsis. So sensory evaluation, if you don't start with what you are starting out with, it is difficult to, there is no metric to assess your success. So I think sensory evaluation and stereopsis measurement should be done, probably possibly even before you do the visual acuity examination. Then of course motor evaluation, which involves cover test, measurements, motility exam, and last part but not least, and no squint evaluation is complete with a fundus, without a fundus evaluation and cycloplegic refraction. So these are essential parts of your checkup. Now I'm showing this child. This child looks as if she has exotropia, not a very great picture, but she just has an appearance of exotropia because of a positive angle kappa, because of the macular ectopia which she has in the on cover test. She had no outward inward movement on cover test. So you must rule this out before you diagnose anything else. So coming to the motor evaluation. So it is basically, what is the goal of your motor evaluation? It is assessing the control and measuring the strabismus. That is what you do in motor evaluation. So assessing the control can be subjective, means what parents report, and as to how often they see it, and how large they see it, and when they do see it. And so that can be subjective, and you can ask parents. They provide you the most comprehensive information about the child because they are with them all the time. And objectively you assess the control by how easy it is for you to see the strabismus, and how easy it is for the child to regain fusion once you have broken foria into atropia. So you assess control. There are some excellent scoring systems also available to assess control, because assessing the control is the most important decision making point when you are dealing with intermittent exotropia. Of course, you will measure the angles. You will measure it for near distance, if possible. Far distance means taking the patient out of your clinic and asking him to look at really large distance. And of course, you also need to measure side gazes because they have importance in dosing, surgical dosing later on. So I'm just going to show a short video. Those who have, please excuse me, those who are pediatric ophthalmologists, they do this all the time, every day, many times. So this is basically how you measure the strabismus. You go on increasing the prism and putting a base in prism. And again, this is SPCT, or simultaneous prism cover test, and this is a prism bar cover test. Okay, I think this video is not working, so let me not. Now, other reason where you would really worry about near and distance measurements in intermittent exotropia is because that has a value in deciding what surgery you are going to do, and who is a good candidate for surgery. And a lot of our knowledge about how to look at near distance disparity in intermittent exotropia comes with the man in this picture, who is my hero in many ways, Dr. Burton Kushner. And when you do see a near distance disparity, means if the near angles are less than distance, you will do these two steps. Addition to your regular measurements, you will do a prism bar cover test following monocular patching. Generally, we patch the eye with squints more often. You will patch for at least 45 minutes to 1 hour and remeasure the angles without allowing child to have any binocular stimulation in between. And if still your near distance disparity persists, means near angles are still less than distance, then you will do the same measurements, putting a +3 diopter lens in front of both the eyes. And that's because that has some decision making potential, and I'll come to it as we move. So you can see this patient here. You can see she has a very good fusion for near, and as soon as I give her a near target, you can hardly see any strabismus. But when she looks at a distance, you can see she has a fairly large strabismus. So you can see almost 30-35 angles I'm measuring, but for near, you can see there is almost no strabismus. So what do you operate for? Do you operate for 35 or do you operate for 0, what I'm getting for near? And so this is the place where you need to put a monocular patch like we do it here. I have patched her for an hour in the clinic. We don't ask them to not to have any binocular stimulation in between, and then ask the open. And as you can see, her near angle is almost built to same like what of distance, and I really don't have to worry about near distance disparity in this patient. So monocular patching is very important part of testing when you do see a patient with intermittent exotropia with a very small near angles or less. Now, once you have done the measurements, now comes whether you are going to operate, how do you manage, whether you are going to use one of the non-surgical interventions or you are going to use surgery as your choice. So non-surgical interventions include correction of the refractive error and treating the amblyopia if there is any, because that's first part of any strabismus management. Observation definitely is an option if it is a small angle, if it is a well-controlled intraocular intermittent divergent squint, a very young child who does not allow you to measure properly, or if the unreliable measurements are there, then observation is definitely a way. And while you are observing, what all you can do, you can use an alternate occlusion because that is known to improve control. You can again give over minus glasses to improve control. In slightly older children, you can try orthoptic exercises, and you can sometimes give prisms to relieve symptoms and to improve the control. So as you can see, this child after surgery given the glasses, and you can see straight away his exotropia is looking better. So glass refractive correction and glasses and patching is a valid way of treating exotropia. So if child has myopia, if he has inappropriate, do not advise for surgery unless you have seen the children with refractive error corrected. Convergence and fusional exercises or orthoptic exercises, they can be either, there are many computer software based exercises are not available. However, in my personal experiences, they are not very effective in young children because young children are unable to recognize the diplopia, which these exercises teach you to recognize. However, in older children, they can be tried as a temporizing method. And the only downside of the exercises are that they are boring and sometimes very difficult to have a long-term compliance in, especially in children, or even in, for that matter, even in young adults. Over minus glasses, there was a time when there was a lot of hype about over minus glasses, because what the over minus glass does is that it induces accommodation and thus accommodative convergence, which leads to better control. And they were found to buy us some time to before we can do surgery in younger children. Principle is to over minus symmetrically. Up to 1 to 1.5 diopters can be prescribed. However, be very careful of watch out for esophoria or esotropia. Worse, esotropia is worse, and if you do see esophoria, they have to be withdrawn immediately. Why I said ki it is now no longer, it's little fallen out of favor nowadays, is because of a large cohort of studies which was done, and they have found a lot of these children are very actually develop myopia of wearing over minus glasses. And I think it is that becomes a little bit of concern. And even the hypermetropic children included in the study did show a myopic shift which was greater than what could have been explained by the age. So that is something we have to think about, and probably I would be a little careful about prescribing over minus glasses in children. Prisms, again, for small angle exotropias, you can try prisms, both ground in as well as Fresnel. If the patient is symptomatic, has diplopia, sometimes they help. Again, but it is not a curative process. It is mostly a temporizing method, because you ultimately these patients need more and more prism to maintain fusion and alignment over a period of time, and may end up requiring surgery sooner or later. So, but in small angle strabismus, people who are not interested in surgery, you can definitely try. Up to half to 1/3 of angle surgery prisms can be given in glasses or as a Fresnel, depending on the deviation what you see. So if you have a say deviation of 15, 16, you can give up to 8 or 9 prisms as a curative, as a temporizing thing. Now comes the surgical intervention. What are our indications? Any poor control means squinting more than 50% of the waking hours. If the parents report that they see squinting often, if you see in the clinic spontaneous tropia, or it's just when you write your notes, you should always write about the control so you can see in your own notes how it is going. So when you say ki it's only single cover is enough to break the fusion, or child is spontaneously exotropic lot of time, then you know control is poor. Similarly, any complaints of asthenopia, or sometimes in older children diplopia, a deterioration in stereopsis. That's why I said ki you should measure that every time. Poor quality of life, because sometimes they get teased about their squint in school, and sometimes they are really upset about that. Any documented increase in deviation, or a failed non-surgical intervention are all reasons why you would operate on these children. So again, nuts and bolts of surgery. When are you going to do it? What is your target angle? What is your choice of procedure? So if it's a well-controlled IDS, better to defer surgery in very young children till you get reliable measurements, because in case if you produce a small overcorrection in these very young children, you are likely to cause more harm than their original large intermittent squint. So 3 to 7 years, I would suggest, is the ideal age to operate. And you can even operate in younger children if exotropia is really constant and has a large angle and you are able to measure with certain reliability. Target angle, again, this comes with some amount of what has been reported in literature and what we have experienced over the time, some of my personal take on it. In children who have good fusional reserves, a 5 to 10 prisms of overcorrection is desirable, or it allows you to have a better long-term outcome of your surgery. However, in very young children, say less than 4, uh, overcorrection can lead to monofixation very quickly, and you have to watch out for overcorrection in these children. So overcorrection in visually slightly mature children probably is all right. In very young children, I would go for ortho or slightly undercorrection. In adults, orthophoria is always possible. Closest to the orthophoria is your goal. And in myopic children, probably it's better to do a little undercorrection, because they tend to go for a little overcorrection more often because of the anatomical features of a myopic eye. Now, what are the procedure of your choice? You could do a unilateral recess resect procedures, or you can do a bilateral lateral rectus resection. And that may be influenced by the type of exotropia. That's why it's important to see whether there is near distance disparity. So if there is basic type of exotropia, means where near and distance angles are same, you could do a recess resect as well as bilateral lateral rectus resection. But in case where there is a distance angle, despite your monocular patching and plus 3D, if the angles continue to be more for distance, you would choose a bilateral lateral rectus recession as your choice of surgery. In children who have high AC by ratio, means their near angles increase only with plus 3 diopter lens, those are probably not great candidates for surgery, and you should probably look at non-surgical methods in those. Again, pattern deviations which are there must be addressed by appropriate surgery when you do a plan surgery. So these are my personal takes. Really, there are no hard and fast rules about this, but I would prefer a unilateral surgery in adult, in children who are, or even in young adults who are poor candidates for general anesthesia. Moderate to large angles, I prefer a unilateral recess resect, because in my hand that works better. In amblyopic eyes or eyes with poor vision, or if there is a very strong fixation preference for other eye, I would look at unilateral as my recess resect as my procedure of choice. In children with mild to moderate angles with freely alternating with no fixation preference, I would probably choose a bilateral surgery because it gives symmetrical results. In a true divergence excess, where despite all your attempts, if the near angles, distance angles are more than that of near, you would choose a bilateral lateral rectus recession as your choice. Presence of a pattern like A or V, where you have to probably address oblique dysfunction in both eyes, again, bilateral surgery would be your choice. In a very large angle, I would probably choose a bilateral surgery rather doing supramaximal surgeries in only one eye, which leads to incompetence in side gazes as well as narrowing of the palpebral fissure. I would rather divide the surgery between two eyes than trying to correct everything in one eye. So some examples like this child who had constant right exotropia, fairly 35 to 40, I chose to do a recess resect in the right eye, and she did well. This child again, because she had bilateral inferior oblique overaction, I chose to do a lateral rectus recession in both the eyes along with inferior oblique recession. And as I said, there are many ways to skin a cat, and you should do what works best in your hands. This is again a child who has a mild to moderate angles, as you can see, and he did well with bilateral lateral rectus recession. This child again, a V pattern with large inferior oblique overaction both eyes. I chose to do inferior oblique bilateral lateral rectus recession with inferior oblique recession, and as you can see, you have corrected both the things, is V pattern as well as exotropia, with a single surgery. This patient, again, a large A pattern, you can see from here versus here, and superior oblique overaction on both sides. I did a lateral rectus recession with PTSO in both the eyes, and we have fairly good results with that. We did a superior oblique posterior chenectomy and lateral rectus recession. This lady, again, very large angle, has DVD with a large A pattern. I know I could not have dealt it with only single, although she squints more often in the right eye. She has slightly less vision in the right eye, but I could not have handled 65 PD of exotropia with only one eye surgery. So we did go ahead and did PTSO as well as lateral rectus recession in both the eyes and medial rectus plication in one eye. This is what we did, and you can see she still does have a little bit of DVD, which is residual remaining, but cosmetically she is happier with her appearance and she does not want further surgery. So what are the factors which affect surgical outcomes? Age, of course. Slightly older children, you get slightly better assessments and magnitude of deviation. Children do really well if there is angles are between mild to moderate, say around 35 to 40, up to 40. Presence of amblyopia is leads to poor success if you don't address it before you do the surgery. So amblyopia must be addressed as far as possible before the surgery. Type of exotropia, as I said, those who are have high ACBA ratio, means their distance angles, near angles are much less than that near, with a high accommodative convergence. They are not. They are likely to have diplopia for near post surgery, and there I would probably defer surgery in favor of other non-surgical methods. And immediate postoperative deviation, if you have residual exotropia, you know this is going to drift. So immediate postoperative deviation also gives us a clue about how this child is going to do. Undercorrections are very common, and common causes of undercorrection can be presence of amblyopia or poor vision, failure to uncover full extent of exotropia, not addressing oblique dysfunction. These are common causes where undercorrection happens. Even despite best efforts, sometimes undercorrection does happen in exotropia, and you should probably counsel pre-op to prepare the parents for this. And management of undercorrection can include orthoptic training in the postoperative period, sometimes prism glasses, and of course, if the angles are larger or drifts to a more larger angle, you need to do a resurgery. Overcorrection, more scary, especially in children, because esotropia is amblyopiagenic than residual exotropia. So that should not be left for time to take care of itself. No, that you should have to see these children very closely. If even if you have intentionally produced a esotropia, please follow them up. And if esotropia persists beyond 6 weeks, you should patch. You should give full isotropic correction. Prisms, if you think that prisms will take care of that. And yes, surgery, resurgery, or to correct the overcorrection is probably not something I would sit on it for 1 year, 2 year. I would probably wait for 3, 4 months and then plan for a resurgery. When should you refer, worry, or investigate? If there is exotropia associated with unexplained poor vision, is exotropia associated with any acquired motility limitation, you need to worry. Any exotropia post-trauma or post-following surgery in neurological surgery, orbital surgery, or ENT surgery, you need to probably refer, worry, and investigate. So just closing with this example of this 35-year-old who came with a little less vision in 6/18, and he had a previously recorded 6/6 vision in his thing. He didn't even come for exotropia. He came for allergy related complaints. And if at all, there was only a slight elevation limitation, nothing else, but had trace RAPD. So we did an MRI and found a circumscribed oval lesion extending to the probably a nerve sheath tumor. Unfortunately, he never came back for follow-up and did not believe what I said to him. I hope he is doing well wherever he is. Thank you for your attention.
Thank you, Dr. Sumita. It's a wonderful journey of complete intermittent exotropia. So we felt that you revised everything, including your own. Just I wanted to know, suppose the children, small children, and if they have their other neurological problem like delayed developmental milestone children, they come like CVA children. How do you approach these children with intermittent exotropia? Because it is difficult to measure the exotropia
Yes.
doing
So
occlusion test or
in children with neurological issues, most often exotropia we see with CVI, associated with CVI. Again, they are poor candidates for very early surgery. If it is a esotropia, I would probably go for a little earlier surgery, like I would deal with other. But exotropia, there are no clear benefits shown by doing early surgery. So you can try all the other methods which we said. You give glasses, you try alternate patching or patch the dominant eye as far as possible. And maybe once you have relatively okay measurements, you can plan for surgery. But these children is where the drifts are very common, and you must counsel the parents ki even if you are doing the surgery, they may need additional surgeries in future. I think that's what I would do. I probably would not advise for a very proactively at surgery at 1 year of age, but at 6 years, if I see the squint, I would offer surgery, definitely.
yeah, because sometimes alignment helps in their other therapies
Yes,
actually, vision
yeah, but
therapies.
the evidence is not so great for exotropia. Esotropia, yes. Again, esotropia, you probably would not apply the same standards what you would do for an infantile esotropia who has no neurological issues. But there is some evidence which exists that early esotropia surgery helps. I'm not so sure about exotropia.
Exotropia, right. And in your experience, whenever there is a small intermittent exotropia and offering orthoptics, we
As I
experience
said,
that those candidates
I
improved
have
over
not been
time.
I have not been very happy with orthoptics in children because they fail to recognize. After all, what do you do in orthoptics or what do you do in these exercises? You are teaching the children to recognize the diplopia which comes with divergence and using their own fusional and convergence mechanisms to control it. But this training and teaching in younger children they don't recognize it at all. So your pencil push-ups in a 4-year-old child is just probably exercising the biceps, not really the convergence, because he does not recognize it as diplopia. But yes, young adults, say, or older children, definitely you can. But problem is
You
only with
wait for
compliance.
this.
Problem is compliance. Children are not willing to do that. That's the issue with orthoptics. But yes, in a 12-year, 14-year-old, if there is a small less than 20, I would definitely offer orthoptics as. And now there are many options available in orthoptics. It's not just pencil push-ups, cat cards, and
Oh,
rock strings and all. Now there are software-based.
BTS is also that.
Yeah, there is so many other newer modalities available to train convergence. But training convergence and in very young children, I feel it does not
Not
work.
satisfactory.
Not very. I would offer in a slightly older child, say 10 years and above. I would like to know what Dr. Pradeep thinks about it. They have had an
Yes.
extensive experience
We are waiting for sir also.
for orthoptics.
Pradeep sir, hello, what is your opinion, sir?
So I agree that orthoptics is very important. I would rather say that because the final result is going to be binocular vision. We need to first see how much is the stereopsis and binocular vision first before even in a child who is 4 years old, I can see that he can easily tell us about stereopsis. So if I check the stereopsis, which is mostly available for near, you can easily see how much stereoacuity he is already having. And fusion exercises do help us in actually such a deferring the surgery if you are doing, and in a qualitative way that we know that he's not being harmed. So even if you're deferring a surgery in a 4-year-old child, keep on checking the stereopsis, and you would know that, yes, this is a time when it's going down. Even for near, you shouldn't delay anymore, and you should do the, and after the surgery also, the exercises are required. So these, if you explain the exercises properly, they are very helpful. Recently, we had conducted the study using the binocs online, and we found that that works. So definitely exercises is something, because we're dealing with muscles, which are dynamic structures. Whatever surgery you're doing is not going to last forever. And that's the reason why we fail many a times. If you explain exercises to any child or even an adult, the results that you will get will keep on lasting for long time. So my say would be, don't forget the exercises. Exercises are a part of your thing. Just like physiotherapy is required after orthopedic surgery. So similarly for squint surgery, if you do and then you follow up with the exercises, it does maintain the results better. And here the important thing is sustenance exercises. So just doing pencil push-ups is not enough. You need to ask him to hold it for a minute at about 6 inches from the nose, and then 10 seconds break, and then similarly for 5 minutes. And this exercise keeps the results very good for long years.
I have one
Sir, I
question
have a
to
question,
ask.
sir.
Okay, we're
Uh,
ready.
So one question is, after you, yeah, can I ask? Yeah, after you have
Yes,
done
yes,
all the
ma'am.
surgery, you have hello, can you hear me?
Yeah, we can.
Yeah, go
Yes.
ahead.
Hello. So after we have used up all the muscle for a very high exotropia, now you have also a small angle exo which is remaining. Does this exercises help, sir?
Yes,
Basically,
I
because
think,
one of my
Yeah.
patient is
So
Yeah.
exercises are going to help
taking,
you for that.
yeah,
In
but
yeah. Carry on. Yeah. What's your question?
sir, but is it helping us to control, like the fusion is coming, but still the angle is still remaining. So the patient is very worried what next has to be done. So I had that thing, how long can we take up this exercises in these cases?
So see, if it's for a general purpose, if you can maintain exophoria with the help of exercises, it's good enough. It's only a question when we are dealing with the prospective pilots who want to take up the exam, where the fitness is required, and there the critical thing is 6 prism diopters for distance. So there it's important that we have to intervene and do a surgery. So we want to get them back to less than 6 prisms. Otherwise, for civilian jobs, mostly exophoria is fine. Even I would be having a 14 prisms exophoria since ages, and it's not a problem for me. And similarly, most of the people, if you see, exophoria is not a problem if it is well managed.
Sir, and one more thing, when we
exercise probably in, I'm not sure about very young children. Sorry saying very, but my experience is a little different about very young children. 4-year-old is very difficult for me. But older children, sometimes you can keep them as exophoric post-surgery. So I think there is a role. As I said, sometimes undercorrections are very much part of our life. And definitely there is a role for orthoptics in that particular scenario in slightly older child. I'm not really sure about 4-year-old, but
and actually my age limit is not 4 but 7 years for keeping under corrections.
Yes, 7 years probably, yes.
So
They
even till
understand
7
what
years, I would rather keep under correction and not risk a consecutive ESO, which is very, very disabling to the patient as well as the surgeon.
Sir, in your experience, have you seen any patient who is on orthoptics binocs therapy and like after giving for 3 months or 6 months, the patient has recurrence, like increase in deviation or frequency after stopping the therapy?
The deviations are not going to change.
Yeah.
Usually, if he's doing exercises, the deviations will not reduce, first of all, because many a times they feel that the exercises will reduce the amount of measurement that you make. No, it doesn't. So that is a fact. As far as the progression is concerned, yes, over a long period of time, the exophoria can increase in measurements also, but that takes time. But yeah, exercises usually keeps them in check. We have had, I mean, almost like those had operated maybe 20 years back, 25 years back, those children are also doing good if they have been doing exercises. So many of them, they have remained exophoric if they have done exercises. It primarily depends on how regular in your exercises you are. And it depends upon you how strongly you emphasize this part.
So how long we should give the orthoptics? For 6 months or 1 year, maybe more than that? When should we stop it?
I think you can probably give it a 6 months of some software-based therapy, but pencil the home things like CAT card and all, they can do it all their life. All the
In fact,
That's
the
why
online
sometimes compliance
sign-off is
comes
only a
in.
month. The
Yeah.
paid one, which is usually
Only
we
for
ask them
1
to
month
do
or
for a
2
month.
months, yeah. So you can build it up with CAT card and block string and other
Correct,
things which
correct.
they can do at home.
Exactly.
And also, if the angles are also important, if your residual is around 20, 25, I think go ahead and do the surgery, resurgery. That's why all that counseling chair time is required pre-surgery. Because
So
despite
what is
our
the
best
maximum angle? Yes, ma'am. Ma'am,
despite
please.
our best efforts, sometimes residual there is. Sometimes I have had disappointing. I have operated for 40 and still ended up with 20, 25.
So that can happen in
Yeah,
some.
that can happen. I mean, that's the truth of the matter. There will be occasional very surprising results. So you should talk about resurgery options always.
So mainly the control score or the angle, which actually drives our decision. So this is
The
like
control. I think the
Yeah.
control is more important than the angle. Angle doesn't make any difference.
Yeah. So mainly
If control is excellent, you can wait.
Yeah.
If control is excellent, stereopsis is excellent, fusion is excellent. Yeah. Because surgery is not perfect either.
I think we'll move on to the next case with Dr. Vivek, the esotropia in children, evidence-based management. So, Dr. Vivek, can you share your slides, please? Hello. Yes.
Yeah, hi. Can
Yeah,
you
we are
see
able
me?
to see. Yeah, full screen only.
Yeah, can you see me?
Yes, full screen. Yeah.
Yeah, so good evening to everyone. Thank you, Dr. Sucheta and OSA's team for giving this opportunity and give this particular lecture in this forum. I'm sure a lot of residents, fellows, and probably the general ophthalmologist they are attending this webinar. So I am going to talk about esotropia in children. What is the evidence-based management? I do not have any financial disclosure. So basically, I'll take you guys through the how to classify the esotropia. I think esotropia is a very broad terminology. So there are a number of things that come into this entity, but I'll talk about predominantly, the infantile esotropia, refractive accommodative esotropia, then partially accommodative refractive esotropia, and again a very important esotropia entity, what we do as a strabismologist call it as acute acquired comitant esotropia. And then whenever required, I'll try to give some interesting clinical cases to make it more simple. So if you understand, before understanding like how to deal with the esotropia per se, I think it is important to understand what is the normal neonatal alignment. So if you see 70% of the newborns, they are usually having transient exotropia if you compare with esotropia, which is very less common. However, almost like 30% of the children's, at birth, they are orthotropic. So if you see the normal Virgin's lock mechanism that usually happens 3 to 5th month of the life, post life, natal life, that get establishment of the binocular connections in the layer 2 to 4 of the visual cortex. So in simple term, this Virgin's lock mechanism is the brain's ability acquired during the early infancy to use the binocular visual information to keep both eyes accurately aligned and working together as a single visual system. So once we understand this, then that's how there are different entities, may it be, like esotropia, or for that matter, high accommodative convergence, uncorrected refractive error, or genetic components, or a number of, the other factors that probably would contribute to cause, the immature visual system. So again, it depends upon whether this immature visual system is because of, the deficient or delayed development of motor fusion, or if the children or they do have the normal motor fusion, then ultimately they'll have the proper symmetry of OKN that leads to the ocular alignment with normal sensory and motor function. However, if there is a deficient or delayed development of motor fusion, as we see, especially in cases with, the infantile esotropia, then usually they would develop the nystagmus, or they would develop the latent manifest nystagmus, and that's how this subset of patients, they'll have a very typical, the asymmetry of OKN, and that keeps persisting for rest of the life. So how to classify the esotropia? Probably this is the broader way to classify: comitant, concomitant, and secondary. So within the comitant variety, you would see accommodative, non-accommodative, then, the microtropia, nystagmus blockade. In concomitant, paralytic, non-paralytic, and secondary, it could be, sensory and consecutive. So I'll touch upon what is the accommodative component and also the non-accommodative. So I think, considering the time, probably I will touch upon these two topics, and I'm sure, the paralytic and non-paralytic or a consecutive, probably, Dr. Sharma will cover that particular part of this classification. So if you understand, these two types, like non-accommodative and accommodative, you can see these are the group of esotropias that we do come across in our day-to-day practice. So infantile esotropia, it has a consistent features. As you can see that it is onset at birth or 6 months, then it is a large stable angles. They do have a cross fixation. Then they can develop over a period of time, the preference of fixation. And then when you check the OKN, probably you would get, the NTA, that is a nosotemporal asymmetry. And usually these patients, they do not have the CNS abnormality. So considering this consistent feature, probably clinically you are labeling it as, the infantile esotropia. So you can see this example where, the temporal to nasal stimulus produces a very strong OKN response. However, from nasal to temporal stimulus, that produce a weak or sometime, the absent OKN nystagmus. So what happens when there is a persistence of this NTA, that is considered as evidence of abnormal binocularity and immature cortical visual pathway. So this test probably help you to understand, how's the binocularity and is the cortical visual pathways mature or immature. Apart from the consistent features, you would come across these variable features like, having excessive adduction, upshoot or downshoot in the form of, the inferior oblique or a superior oblique overactions, what we call it as, the A or V pattern. They do have DVD or DHD, and then they adopt, the anomalous head posture. Again, they can present with manifest latent nystagmus. So I think these are the features where you can try to put them more in favor of, the infantile nature than probably the acquired nature. So I think to start these patients to evaluate, I think it is very important to look for, are you dealing with the pseudoesotropia? And I think most of the parents, they come with, a lot of anxiety. So I think you need to look at how's, their external facial features in the form of prominent epicanthal folds, broad nasal bridge. And again, very important is, how's the HBT? The HBT is central. If you do a cover test, if the child is cooperative, probably they are orthotropic, and usually they would have the normal ocular motility. So I think once you are pretty sure we are dealing with pseudoesotropia, then rest of the games that start when we see the patients with actual, the isodeviation. So if you see this particular example, the typical infantile esotropia child who has presented with, the inward deviation, then usually again it is very important to ask, the birth and developmental history, not as a part of typical infantile, but as a routine strabismus evaluation. And again, the family album tomography is very, very important. So this particular child has a very classic feature of, the infantile esotropia, as you can appreciate in this slide. So he had infraoblique overaction. He is probably at this time point fixing with the left eye. And then you can see that they have all these three type of fixation patterns in infantile esotropia, may it be cross, alternate, or monofixation. So how to manage the infantile esotropia? I think the optical correction, that is correction of the refractive error, like full cycloplegic refractive correction you need to offer. Whenever there is amblyopia, we need to treat amblyopia. Then there are many studies which talks about use of Botox injection whenever there is a small angle of deviation. Although in my practice, I have never used Botox in patients with infantile esotropia. And then the mainstay of the treatment is probably, the surgical correction, depending upon how much is the deviation, very similar to, what Dr. Agarkar talked about the exotropia, like how large is the deviation in a primary position. So you can use bilateral medial rectus, or you can use, one eye R and R, other eye you can touch one more muscle, or if it is a very large, you can use four muscles. And sometime nowadays, like you can take help of, the muscle transposition procedures when patient is demanding not to touch to the both the eyes. Again, as we understand that the infantile esotropia is associated with oblique overaction or underaction. So again, you need to think about whether it is associated with oblique overactions. So depending upon that, you can take a call and combine these bilateral medial rectus with infraoblique transposition procedures. If they are not associated with that, but there is a difference between up and down gaze, then probably you can use this particular method of, shifting LR to up and MR to down for V patterns, and for A pattern shifting MR to up and shifting LR to down. So which is a very standard of care for a strabismologist. If you look at the literature, I think this particular study really talks about and make our understanding that, usually the esotropia is larger than 40 prism diopter. After 10 weeks, probably they don't resolve on their own, and ultimately they would need the surgery. This is another very landmark study called as, the ELIS trial, who has shown the significance of, the early surgery, how it can helps to gain the gross binocular function. Although the resurgeries is pretty common as you do earlier surgeries, again, depending upon, the n number of factors. So this particular case, if you see 6-year-old female child, she had a very large deviation of almost 75 to 85 prism diopter. And this is how we were talking about, like how you can utilize, touching both the eyes and getting away with a very good outcome. So this patient had undergone bilateral infraoblique transposition with one eye R and R and other eye, the medial rectus. So you can see on follow-ups, they do give a good outcome. Now, before moving on to the thing where, we really need to think about what are the differentials of infantility. I think this particular example was very interesting, where you need to look for when there is a abnormal version, always check deduction. Close one of the ends, see what's happening with the abduction. So with this, I think we need to keep, the other mimickers where sometimes, it is an acquired nature, confusing history, parents are not sure. Think about RAET, give them glass, wait for some time and see how the, esotropia behaves. Then also the congenital sixth nerve palsy is again one of the close differential. We should again look for ductions. If doubtful, you can elude by doing MRI brain and rule in the congenital sixth nerve and not the infantile esotropia. Acute acquired comitant esotropia is again you have to really think, and I'll try to cover that particular entities and various classifications. DRS type 1 with esotropia is again has a very characteristic feature, palpable fissure changes, upshoot and downshoots. Then the Mobius syndrome, again, the facial asymmetry, classic facial features in unilateral or bilateral Mobius that helps to sort it out. And again, last but not the least is, the sensory esotropia that you need to always keep in mind while dealing with infantile esotropia. So if you look at this was our last year experience where we have presented this particular data, how you can use, the infantile ET with extra large esotropia and get away with by doing, the true muscle transplantation, which is not a new procedure. We have tried it in sensory strabismus, exo as well as esotropia with a very good outcome. So this particular boy had presented with a very large angle esotropia where we offered him the muscle transplantation. So this is a procedure where basically normally we do R&R, so we resect the the lateral rectus and throw it away. So here you don't need to throw it away. Take that the segment of the lateral rectus and transpose it to the medial rectus. So if you see this particular procedure, it is very easy. You don't need to even change the sutures. Many strabismologists, they use the non-absorbable suture, or they would change the suture material, but you can go away with what suture you are using, and still this particular procedure has a very good outcome. Now, how much to use the resected segment, that again depend upon how large is the primary deviation. So if you see the outcome of this particular procedure, I think it has given a very good outcome in patients with esotropia, and that is how this particular a paper we try to elude. It is even useful in not just a sensory esotropia, but it can be used in patients with infantile esotropia. Okay, so as you can appreciate here, so you need to anticipate that loss of some sort of the tissue. So if you are planning 5 millimeter transplant, probably you need to take a more resection around the 7 millimeter. So that's how you can do the primary reattachment of the lateral rectus, and then transfer this particular segment to the medial rectus, which we have the plan to recession. So I think surgical procedure wise, it's a very simple to suture end to end, and I usually give one middle suture also to have a good apposition, so that they should not be losing the muscle into the orbit. And that's how you can complete this particular procedure. So if you see the post-operative outcome, I think it gives a very satisfying outcome in long run. Also, this particular patient of 4-year follow-up, you can see that there are no palpable fissure changes. Why there are no palpable fissure changes? Because we have not gone beyond the physiological limit of recessing or resecting the recti. So we have just increased the length of the muscle. So that's how it helps not to create the palpable fissure changes and even the lateral incomitants. So moving on to the next entity, I'll talk about refractive accommodative esotropia. I think again this is very important that this particular entity is more common in an average age group of 2 to 5 years. It is frequently associated with amblyopia, And again, the angle of esotropia, which is approximately the same at distance and near. And again, when generally it is around 20 to 30 prism diopter, although we have seen a very varied amount of deviations in patients with refractive accommodative esotropia. Okay, on an average, hyperopia, usually these patients do present with these around 4 diopter. So what is the basic mechanism? What happens? How do the RAT develops? So when the uncorrected hyperopic refractive error, it leads to the retinal blur, and then we usually by convention either we accommodate or make no effort to accommodate, because having very high plus power. So when we go no effort for accommodation, then it leads to orthotropia. But usually these patients will end up with developing the bilateral ametropic amblyopia. Now, if we accommodate the patient, accommodate more, then that leads to, for a unit accommodation, there is a accommodative convergence. And then at this time point, if there is a accommodative convergence is happening, and then the patient has an insufficient fusional divergence, that means ability to take the eye out is less, then obviously it would end up with causing the refractive accommodative esotropia. If it is sufficient fusional divergence, then usually they would not completely go into a kind of the manifest esotropia, but probably they would end up with having some sort of esophoria. And if it is normal, normal AC by ratio, then they may not develop the esotropia, although they might have the high hypermetropia with amblyopia. So this is a child, a very young child with having high refractive error, and you can appreciate that there is a large esotropia of almost 40 prism diopter. So by giving full cycloplasic correction, these childrens, they would become orthotropic after giving a simple glasses. So I think here you need to educate the parents, that this type of strabismus, there are two types where they are dependent on glasses, and another one is they are not dependent on glasses, which needs actually the surgery. So this is another example where you would see the large esotropia, and then you do the cycloplegic refraction, give them glasses, wait for some time. You would find still the eye is isotropic, but this eye is not as isotropic as it was, at baseline. So this child was almost 60 prism diopter, but after giving glasses, almost 50% of the isotropia got corrected. That means this is a case of PAET, where you actually ultimately needs, the surgery. But when to offer the surgery, probably you need to wait for a sufficient time where you have taken care of, the amblyopia. So it doesn't matter. It takes 3 months, 6 months to understand that, the visual improvement after amblyopia therapy with a good compliance. And then at the end, probably you can offer them to go for surgery, and these children do very well. Now to do BMR versus R&R, again, the concept is more or less same, depending upon how much is the primary deviation and which eye is the amblyopic eye. So you can choose R&R in amblyopic eyes. Moving on to the third entity, it is acute acquired comitant esotropia. I think this particular entity is very much important, which we realize probably the post-COVID era would be the trigger for this. So this group of patients, they'll have usually the normal motility, refractive error may not be that significant, they have a good binocular potential, and usually they do have a normal neurological examination. So if you see this particular, friends, Dr. Burian and Miller, they come up with this first time 3 types of classification system: type 1, Swan; type 2, Franchisetti; and type 3, Belchowski. So I'll not go into the detail, but Swan type is when, there is a history of, the occlusion. Usually this patient develop sudden onset esotropia. Franchisetti, again, they don't have a very typical signs of, the paralysis, but they present with diplopia. They'll have a larger deviation. They'll have the low refractive errors, like either towards the side of, the emetropia, low hypermetropia, although the exact cause is not known. Type 3, initially, the people used to say, it is a myopia of less than -5, and they do present with esotropia. So after particular this case, you can understand that this particular child was absolutely normal to 1 year back when he presented at the age of 7 years. He had a history of acute onset inward deviation over a period of 7 months with very large esotropia with normal motility. And then after surgery, she did very well. So these are the probably examples where you would put it into different categories. For example, this patient had +5, so I would put it into type 2 franchise looking at other two types. But if you see in 2015, this particular paper changed the way we look at or classify the AACE. So they have classified is type 1 as a SON, not different from the initial classification. Type 2 Barian or a Franciseti. Now they are calling it as the idiopathic, and then usually they are associated with anxiety or psychological stress as one of the mechanism in this group of patient. Type 3, again this is a acute accommodative AACE where hyperopia is more than 3. However, in original type 2 the hyperopia is less than 3. Then type 4 decompensated. Type 5 is a neurological. Type 6 is a cyclical, and then type 7 is a secondary AACC because of the other sensory reasons. So if you see the neurological AACC, I think this should be the highlight of my talk, that all AACCs, you need to be very careful in terms of asking them history of neurological deficit. Always look for their old photographs, how do they look like, and then depending upon that you can try to classify them. So this child has a 30 prism diopter of esotropia, and on fundus examination he had a papilledema. So basically, on MRI brain, it turned out to have a very large tuberculoma. So I think again the neurological AAC is very important. We should be careful, and raise ICP symptoms make underlying CNS disease understandable. But in those cases where the signs are absent, then probably you need to look at whether this AAC is associated with nystagmus. Is there any, A or V pattern, large angle deviation for distance, especially in children's, and loss of vision? This history probably, help you to really consider neurological type and send them for neuroimaging before you actually operate these patients. We had published our experience almost 3-4 years back, where we have seen the similar trend what has been published. And neuroimaging yield is not that great, but still 16% a patient had a positive neuroimaging finding. So with that context, I think all patients of AACC, it is worth to neuroimage and then take a call for the surgical intervention. This is the last type probably I would put is a cyclical. So exact etiology is not known. It usually comes in the cycle of 48 hours, 24-hour ortho and 24-hour esotropia. They are usually associated with pattern deviation, and diplopia is a classic feature in patients with adult, because the children usually suppress, they don't understand, and that's how they do present. It's a very rare. I have seen 4 or 5 patients in my practice. This particular patient, if you see that 24 hours, she is absolutely straight. So then how to take care of these patients? The ultimate treatment is actually the surgery. So you do a extra large MR recessions, or you can add a fed-on procedure to really make these children straight. So I'll stop here, and I would like to invite all you guys for POSN 8th edition that is happening this time in Bhubaneswar on 19th and 20th September. Thank you very much.
Thank you, Dr. Vivek, for this elaborative talk. So, with the lack of time, we'll take all the questions at the end. I think I request Pradeep sir if you can start sharing your slide. So, Dr. Sharma will discuss about the complex strabismus.
Dr. Vivek, can you unshare first?
Yeah, I think so.
Vivek, can you stop sharing?
Yeah, I am trying it, but it's not happening.
Oh.
You close it and then stop sharing, right?
Yeah. Yes, it's done now. Please see.
Done.
Sorry for that. Yeah.
So at the outset, I would like to thank the organizers of the Odisha Society for making this possible. And we are having this talk on complex strabismus simplified, but since it is itself a complex subject and the time is limited, I would here be just talking about the non-paralytic variety. I have no financial interest involved of any kind in this present talk. Thanks for your love and affection. So complex strabismus, when we are dealing with, we'll be talking about the restrictive strabismus, and nowadays we talk of them as the congenital cranial dysnervation disorders, primarily the Duane's retraction syndrome, Brown's, Mobius, congenital fibrosis extraocular muscles, the synergistic divergence, and the SID syndrome. Then also the other restrictive conditions like the dysthyroid eye condition, other restrictive problems maybe because of injury. Myopic strabismus is a very important subject which needs to be covered up, and the dissociated vertical deviations, and finally the skew deviations if we have time. So the ESO-DRS as an example, if you see, they are classically seen as esotropy in the primary position, and in adduction there is a upshoot and downshoot along with the retraction, and there is a limited abduction. On the other hand, the exo-DRS has a common feature of the retraction and narrowing of the palpebral aperture in the adduction, but they may have some abduction and they have an exotropia in the primary position. There may be associated syndromes with the DRS like Golden Haar, Klippel-Feil, the Wildervanck, Holt-Oram syndrome, Oki-Hiro, DRRS, and the IVIC syndromes. What is the basic underlying pathology in this condition? It's a paradoxic innervation of the lateral rectus. Like in the left exo-DRS is the left lateral rectus. During abduction, it may have a little bit of abduction. That means it is getting its innervation. But during the adduction, it fires fully when the medial rectus is also active. So there is a co-contraction. And this co-contraction in adduction is the primary problem in Duane's retraction syndrome. This co-contraction also causes slippage of the globe, which results in upshoots and downshoots. So how do we manage? First of all, in Duane's retraction syndrome, we have to notice that whether it's an ESO, exo, or orthotropic Duane's retraction syndrome. Second point you need to take into account is how significant is the co-contraction. As definition, co-contraction is always there. We are just looking for the severity of the co-contraction. If it is more severe, there will be a marked upshoot and downshoot. And if it is minimal, then the upshoot downshoots would be minimal and the retraction alone will be visible. How much is the normal LR activity is the third point that you have to keep in account. And finally, the force reduction test intraoperatively for both medial rectus and the lateral rectus, and especially in the ESO-DRS, the medial rectus. So the algorithm that I would like to share with you is that if it's a unilateral or bilateral, that you first separate. If there is a minimal co-contraction, then you look into how much is the deviation in the primary position. Is it less than 20 prism diopters or more than 20 prism diopters? If it is less, then you look for that you may be able to handle it with just an MR recession as per the FDT, or may add on to a SRT or a IRT or a PVRT, but this is something which we can only do if the lateral rectus paradoxic innervation can be taken already neutralized. If it is more than 20 prism diopters in ESO-DRS, you may have to keep the MR recession low on that side and do an asymmetric larger MR recession on the normal side in order to take care of the ESO deviation. If there is a moderate to severe co-contraction, you always need to balance the MR recession with the LR lateral rectus recession, which is also on a Y split. So let's see some examples. An ESO-DRS in the left eye here, the FDT for MR was free and there was a minimal co-contraction. So in such a situation, you may get away with just doing a superior rectus transposition, which will improve the ESO in the primary position and give some abduction also. On the other hand, if you have an ESO-DRS with an FDT for MR being positive, you will definitely have to do a recession of the medial rectus. But this has to be kept in mind that this has to be minimal that is required just to release the FDT. If you do a large MR recession, then it may result in an iatrogenic synergistic divergence. So here, just a 4 millimeter MR recession has been done. It has corrected the EZO as well as the retraction. Any extra MR recession, as you can see here, can result in an iatrogenic synergistic divergence. Now, this is a situation in which you need to balance the MR recession with the lateral rectus recession, which is also with a Y split. And the Y split has to be 22 millimeters or so between the two arms of the Y. So in EZO-DRS, minimal MR recession as per the FDT, LR recession should be always added to if there is a significant co-contraction. And if you have taken into account the co-contraction altogether, then only you can do an SRT or a VRT or a vessel sparing partial VRT. When do we do bimedial recession, as we talked about? You may do an asymmetric MR recession. Like in this case, you see here, the MR recession on the side of tight FDT was 5 mm, but the rest of the EZO has been corrected by the medial rectus recession of 6 mm on the normal side, and it also helps in improving the abduction. In EXO-DRS, how much do we do? On the basis of the exotropy and the primary position, how much is the co-contraction, and how much is the normal lateral rectus activity in abduction? The procedures that can be done are LR recession with Y split, or you may do a large 12 to 18 millimeters of LR recession. Periosteal fixation of LR or extirpation of LR are extreme procedures which are only done if there is no abduction at all and there is a large EXO-DRS. Now, the algorithm that we follow here is that if there is a normal LR activity and there is overshoots or undershoots are not so much, you may just do an LR recession. If there is a large upshoot and downshoots, then you have to do an LR recession with Y split. If there is no LR activity and there is a large EXO-DRS with a severe co-contraction, you will have to do a periosteal fixation of the LR or a large supramaximal recession of LR with the PVRT. Now let's take some examples. Here, this is an EXO-DRS in the left eye. The XT is, as you can see here, is fairly good. LR activity is normal and co-contraction is evident by the retraction and the upshoot and downshoot. So here I have done an LR recession of 12 millimeters with a 21 millimeter Y split. And this one procedure alone has corrected the EXO-DRS along with the upshoots and downshoots. Little is no good for EXO-DRS, mind you, because here the LR is paradoxic. A small amount of recession may not be of any use, and you may have to do larger recessions or a Y split on the LR recession for the start. If there is a no normal activity, then you may do a periosteal fixation of the LR, and to improve the abduction, you may use partial VRT, like in this case. And after the partial VRT and the correction, you can see that the DRS has in the right eye has improved, as well as the movements are fairly good. In EXO-DRS, pre-op, here you see, and in which LR recession with Y split was done. Now, to further improve the abduction, you may use a modified Nishida procedure or the belly transfer using the superior rectus and the inferior rectus bellies to improve the abduction. Coming to ortho-DRS, if the primary position, the eyes are in ortho position, you may defer a surgery till the person is very keen to get it corrected for the upshoots and downshoots. And such a situation, you have to be careful that you need to maintain the ortho in the primary position. So what we will advise is do an LR recession with the Y split, and the MR has to be on an adjustable basis so that we are not creating any EZO or EXO post-op. So to conclude, in DRS, this will be the situation that we will deal with. This is another case. Now, what do you see here? There is an elevation limitation in the right eye in adduction, whereas the abduction, the elevation is good. So what will be your answer? This is a Brown syndrome. And in Brown syndrome, typically they come with a chin up position, because in the down gaze, the binocularity can be restored with this head posture. So in this situation, how do we handle these cases? In Brown syndrome, you have to take care of the tight superior oblique. So do an FDT intraoperatively, release the tightness of this superior oblique, It may require stripping, or sometimes in a click syndrome, a tight FDT, releasing the tightness may work and you may get away with that. There may be an intorsion because of a superior oblique overaction in these cases. And in such cases, you may have to weaken the superior oblique. Like in this case, you have seen that we have done a silicone expander on the superior oblique, and that has released the tightness of superior oblique as well as weakened the superior oblique in a controlled manner. There may be an associated superior oblique palsy on the other eye at times, like this case which we had published, and you have to handle them separately in the two eyes. Superior oblique weakening has to be done carefully. For a very mild case, you may do a PTSO, but in cases in which you have to do a fairly good weakening of the superior oblique, our choice now is a hangback loop tenotomy for the tight superior obliques, and this is something which works very well. Mind you that if you do a superior oblique free tenotomy, it may result in a superior oblique palsy, and it would add to the problem of even the down gaze, because superior oblique palsy is a worse problem than the Brown syndrome itself. So if there is a right Brown plus in which there is a tight superior oblique, it's better to do a superior oblique hangback recession, which is a controlled weakening procedure on the superior oblique, so that we can ensure that the down gazes, we are not creating a superior oblique palsy. Mobius syndrome is a situation in which there is a CCDD and involving both the sides of sixth nerve along with the seventh nerve, because it's involving the hypoplasia of the pons. And in such cases, you may have associated problems on the face with the absence of the facial nerve functioning and also the other associated systemic features. Such cases, the FDT is usually tied for both medial rectors, and we are usually going to do a bimedial recession in order to correct that esotropia in both the eyes. Congenital fibrosis of extraocular muscles is a CCDD involving the third nerve. While this Duane's and Mobius were only concerned with the sixth nerve involvement, the congenital fibrosis extraocular muscles are involving the third nerve in the embryogenic phase. And the typical thing that we see in CFUM is the perverted convergence. That is when the patient is asked to look up, the eyes go into a convergence. This is on attempted up gaze. And as you see here, it will appear like an A pattern exo. In primary position, there is an exo, becomes worse in the down gaze, and in looking up, the eye go into a perverted convergence. These cases may have associated superior oblique overactions, and we may have to weaken the superior obliques along with the lateral recti. If they have a tight inferior rectus, we will do a bilateral inferior rectus recession. The CFM types, there are several, and this table can be kept as in the mind, that CFUM 1, CF2, 3, or 4, and we may have to deal with each individual case in an individual manner. So like this pre-op case, as you can see here, there was a ptosis and there was a limitation of the up gaze. So there was a tight inferior rectus on both the sides, and we did a bilateral IR inferior rectus recession, and we had to give a crutch class for the ptosis. Muscle aplasias may be there, in which there may be more than one muscle which are aplastic. This is a very serious problem, because then we have very little limited role in doing it. And what we do is using the other muscles which are available to correct for the missing muscles. And here, for example, a bimedial aplasia was there along with the scaphocephaly in this syndrome. What we did was using the superior rectus and inferior rectus for a cross fixation, or we may do a modified Nishida to improve the adduction. So this is a post-op, and this has given us fairly good results after the surgery on the both vertical recti and the PTSO. Synergistic divergence is a typical condition in which once the child is asked to look on one side, instead of adduction, the lateral rectus gets the innervation, which causes a simultaneous abduction or a synergistic divergence. This is because there is an aberrant medial rectus innervation going to the lateral rectus. And for such situation, the most suited procedure is a nasal transposition of the split lateral rectus, NTSLR. And this is a situation in which the NTSLR has worked very well. As you can see, the adduction nerve comes at the right time from the lateral rectus, which is nerve transposed on the medial side. This is a synergistic innervational downshoot. This is a unique situation in which once the child is asked to look on the adduction side, the inferior rectus gets the innervation, which is supposed to go to the MR, and that's why there is a downshoot. And in such situation, what we have found best is disinsert the inferior rectus and transpose it nasally. And these cases work very well after this surgery, as you can see here. A supramaximal recession of the LR along with an IR to MR transposition. Now, this is the video of the same child in which the downshoot has been corrected and the exotropia has also got corrected. Sometimes it helps to do an MRI in a dynamic manner. That means measuring the imaging during the eye movements on the right or the left side. And this will tell us about the size of the muscles which are there in different gazes, which help us in defining which is the muscle which is acting and which is not. So these cases we can handle with periosteal fixation, or we can use the transpositions in a calculated manner. Internuclear ophthalmoplegia is a unique situation in which the adduction is deficient, but convergence is good. And in these cases, many a times it's because of ischemia or demyelinating disease, and we may get the recovery after about 2-3 months of follow-up may help us in knowing that these cases will be managed. And then if necessary, we may do it if required. Strabismus fixus convergence, severe esotropias because of high myopia are a problem which are very difficult to tackle. And in the past, we were handling with large MR recessions, but with the Yokoyama procedure, this case is better handled. Now, if you do an imaging, you will find that the superior and the inferior recti are nasally placed, and the lateral rectus is also in the inferior compartment. So actually in the abduction, there are no muscles, and that's the reason why the eye is in the ESO position. And they may have something like 90 prisms or 100 prisms of ESO. How do we handle them? On the imaging, on the coronal view of the CT, we can confirm that the superior rectus and the lateral rectus are not making a 90 degrees angle, but it's an obtuse angle, which confirms that the lateral rectus has slipped below and the superior rectus is nasally placed. And what we need to do is the approximation of the superior rectus and the lateral rectus in these cases. And that works very well in these sagging eye, heavy eye, or a knobby eye. Knobby eye is a situation in which very high myopia with the staphyloma causes the restricted mobility because of a deformed globe. Whereas the heavy eye is a high myopia in which the SR-LR angle is obtuse and the both superior and the inferior rectus are inferonasal. Whereas the sagging eye may be there with myopia or with aging in which there is a weak SR-LR band, and the advised surgery is to do a loop myopexy, which we are approximating the superior rectus and the lateral rectus. So this is a pre-op picture of a individual having a large esotropia with a bilateral myopic strabismus fixus. And as you can see here, the imaging confirms that point. And what we do is SR-LR loop myopexy and an MR recession to straighten the eyes in all the possible gazes. Thyroid eye disease can also be a problem when we have large deviations or restricted movements because of the tight FDT. And these cases can be seen on the imaging as the typical muscle bellies, which are having a appearance of sparing this, they are spindle shaped, sparing the tendon area. So these cases, according to the FDT, you may have to do a weakening, and you need to see that we do not create an A pattern or also the progressive over recession of the IR. And it's advisable to use non-absorbable sutures for inferior rectus. And since there is a possibility of an A pattern, because both inferior recti are being weakened, which are normally supposed to be adductors, this may lead to an A pattern in down gaze. So it's advised to shift the inferior rectus nasally to prevent this A pattern. Restrictive strabismus may be there because of several reasons. In this case, it was a glass foreign body in the orbit, and that was removed. And afterwards, we have used mitomycin C intraoperatively to prevent adhesions. Acquired MED and DEP, these have to be tackled individually. It may be just a SR paresis or may be associated with a tight IR, or sometimes both are there. So we need to ensure first that the IR is free after the IR recession. And if the IR is free, then we may do a NAPS procedure. Dealing with the management of restrictive strabismus, the points to take home are: do a force reduction test, do an AFGT to confirm that the muscles are normal, non-surgical treatment in the form of anti-inflammatory treatment, oral corticosteroids. Cystic circles, like in this image, which you can see here, there is a cyst in the superior rectus. with the Scolex. And in such cases, you may have to treat with steroids and albendazole for at least a week. And if the fibrosis remains, then you may do a surgery. DVDs are a subject which we are all dealing with, and whether it is an esotropia or sometimes even after exotropia, you may have to deal with DVDs. And these cases, you will typically see that they have a split shifting of the eye upwards whenever the person is not very conscious of it. And behind a Spielman occluder, you can easily identify. So how do we deal with them? We can manage them in this algorithm. If there is a phoric DVD, that means it's only when we examine it and otherwise not manifesting, no surgical management is required. If there is an intermittent DVD, optical treatment to decrease the gap of the vision between the two eyes may help in correcting the DVD. If there is a manifest DVD, then you have to tackle and find out whether there is an associated inferior oblique overaction. If there is an IO overaction, then a total anterior positioning, total anterior positioning will cause an anti-elevation and it will correct the DVD along with the inferior oblique overaction. But if there is no overaction of the inferior oblique, but rather a superior oblique, which is rarely seen, you may have to do a superior oblique weakening along with that SR weakening. If there are no oblique overactions and still there is a DVD, how do we handle them? You may do a SR weakening along with the recession or a Farden, or nowadays what we prefer to do as a procedure is an IR plication in these cases. Here you see an example of a DVD bilateral with inferior oblique overactions, creating a V pattern and IO overaction. And here a total anterior positioning is going to work because it creates an anti-elevation effect. If there is a DVD without inferior oblique overaction preoperatively, so what do you do here? You may do an SR recession, and to enhance the effect of superior rectus recession, you may do a Y split of the SR, which helps as a Farden procedure. This is a pre and post after the SR recession with a Y split. If there is a DVD without inferior oblique overaction, another procedure that can be done is the IR plication, which helps in controlling as an anti-elevation. Skew deviations are fortunately rare. They may be associated with thalamic infarcts, hemiparesis, facial palsy. Many a time they will recover on their own, but if they do not, then you may have to handle them. And they may sometimes confuse you with a superior oblique palsy because they may have an ocular tilt reaction. So how do we see? If you look into the fundus, you will find the intorsion is there in place of an eye which appears to be superior oblique palsy. In superior oblique palsy, remember, there will be an extorsion in the fundus. But in an OTR, ocular tilt reaction, there will be a opposite, the intorsion of the eye which is appearing to have a face turn or head tilt to the other side. And the other thing which has very nicely been shown by Parulekar et al., that head tilt test is positive even in the prone posture in superior oblique palsy, but it is only seen in the erect posture in the OTRs. So once you have this difference, you can differentiate the two. Finally, we just have limited time, so we just need to finalize that these are the topics that we have covered today. And if there are any questions, we may have them if time permits. So now that we are nearing the end, I would like to thank you all for the patience of listening to me. Thank you all.
Thank you, sir. Dr. Suchet.
Hello. So it was a very elaborate
Hello?
entire discussion.
Yeah.
Hello.
Yeah,
It was
Go ahead,
Yeah.
ma'am.
a very elaborate discussion. So you have covered most of the things. So I just want to ask one thing. What is the role of imaging in strabismus? So if you can put few lines on it.
So imaging can be very helpful, especially in the complex strabismus. Hello? Sorry. So
Yes.
in complex strabismus, it can be very helpful. If you want for an academic institution, like when we were doing studies, even Duane's retraction syndromes, Mobius syndrome, or even the congenital fibrosis extraocular muscles, we did high definition MRIs, and they could show that there are absent sixth nerve in the Duane's and Mobius syndrome, and absence or hypoplastic third in the congenital fibrosis extraocular muscles. So these are for documenting the underlying pathology, and that is why we are now saying that these are not purely musculofacial anomalies. Like earlier books, we were used to classify Duane's, Mobius and all as restrictive strabismus or musculofacial anomalies. Now we call them as congenital cranial disinnervation disorders. So that is how we have come to know from the imaging that is work. Sometimes we do imaging to find out what is the underlying pathology in order to help us in management. Like in the synergistic innervational downshoot, you can do a kinetic or a dynamic MRI. That means in different gazes, you do an imaging, and that will show you exactly what is happening to the muscles in different gazes, and you can then plan your surgery accordingly. So that's another use of doing that. In thyroid eye disease, as I showed you, imaging can help you in confirming what kind of condition that you're dealing with. Similarly, if there is a blowout fracture or maybe a foreign body in the eye, or then it helps us. I have not dealt with paralytic strabismus, but if you're going to deal with paralytic strabismus, imaging is going to be paramount. I think in each and every case of paralytic strabismus, two things clinically that you need to do is look for the fields and the fundus in order to see that there is no papilledema, because otherwise you will miss these things. And on the imaging side, always do an imaging whenever you are in doubt. Whenever you do not have an answer that it may be because of an ischemic pathology, like an evident diabetic or a hypertensive person who is having a sixth nerve or a third nerve, and if there is a vessel, pupil sparing third nerve, then you know that, okay, it's an ischemic problem. You may spare the person from imaging study, but otherwise imaging is very important.
Thank you for adding that also. So since the time is permitting, I have one question. What is one practice changing lesson from your most difficult case that you want to give us?
That's, I mean, there have been so many of these complex problems which have always taught us so many lessons, not one. The one thing which I say is that, okay, one is that you can restore the confidence of even the person having the most complex strabismus. If nothing else, you can make them aligned in the primary position so that they can be restored binocular vision in that gaze, and they may be able to navigate their way with a face turn to the different sides. So never say that nothing can be done. This is something I would like to say. A person comes with hope, and in such situations which are complex strabismus, you may have to think beyond your hat sometimes. Think squintellectually, as I say. You may have to do a little bit more exercise, and then you can help the person at least restore his confidence. These myopic strabismus cases, they have been now worked very well with just the SRLR loop myopexy. And now we have switched to doing SRLR loop myopexy without scleral fixation even. So in high myopes, the sclera is thin. Earlier, we were passing the scleral tunnels or all. That's, I think they're useless. You can just do a superior rectus and little rectus myopexy without having to anchor it to the sclera, because here the little rectus is normal. It's not like Jensen's procedure where the little rectus was dysfunctional. So they work very well just with SRLR loop myopexy. So offer the hope with which the person is coming to you, and you may be able to do most of it and restore their binocular vision.
One simple question, Dr.
Yes,
Vivek
Devasmita?
and Dr. Sama. This accommodative esotropia, what we all discussed today, Dr. Vivek said so nicely. So refractive accommodative children, most of the time the parents ask when the glasses will be removed. And after adolescent also many times the glasses has to continue. From your experience, how often you people actually remove the glasses from the child? How many years it takes actually? Is it possible ever to remove the glasses from the child? Hello?
Dr. Pradeep, you want to share your experience?
Okay. So I think this is a very nice question, Devasmita, because practically this affects, hopefully, most of the time accommodative esotropics, after about 11 years of age, their hypermetropia is reduced substantially, but still some may remain. So we do see adults wearing hypermetropic glasses, and we do see children who have had 6/6 vision, even binocularity there, but they are unhappy because they have to wear hypermetropic glasses, especially the girls particularly. And they have a question, what will happen when I want to go for a photo shoot without glasses? The eyes will just squint in because of the accommodative esotropia. One solution is contact lenses. Hypermetropic contact lenses work very well for fully accommodative esotropias. If contact lenses are not going to be acceptable, LASIK has been tried in these children. Unfortunately, LASIK for hypermetropia is not as rewarding as myopes. So many a times we do not get a full correction of that. But yes, contact lenses can be given to these children if they are having a problem. And if possible, LASIK can be tried for the adults who have crossed the age in which there was a change in the refractive error, usually after 18 years of age.
Okay. Dr. Vivek, you are ready.
Yeah, I think my experience is also very much similar, what Dr. Pradeep has shared. Usually, we don't get to see them that completely off, that high plus power. But as per the natural trend, as they reach up to 12 to 13 years, the hyperopia that start regressing. Okay, but again, most of the time, if you see the patients with high SCY ratio, actually they get habitual with that. And even if you try to reduce them, they become more symptomatic. So I think you need to balance them, like at what lowest amount of hypermetropia at this age, which is not, allowing to induce the esotropia. Probably I try to keep at that amount of hypertropia to be prescribing them throughout.
Thank
I
you.
think you can wean them, as Dr. Vivek is saying. You can wean off the
Slowly.
Yeah, one more thing, Dr. Pradeep, I wanted to add. I have seen patient with, the very high myopia presenting as a esotropia, hypertropia. So not necessarily, they has to be like a heavy eye and then they will always be hypertrophy, because the mechanism here is a change in the path of the muscle. So considering that, they can present with either form of strabismus. I mean, hyper as well as hypertropia. So last year we have published this in BMJ case report, where I did a loop myopexy of lateral rectus and inferior rectus to correct ISO and hyper, and that works very well.
Good.
So since we are coming to the end of this webinar, I call our General Secretary, Dr. Santosh Mahapatra, to give the vote of thanks.
Good evening, everyone. It was really nice to listen to all the stalwarts in strabismology. And I'd like to thank Dr. Sucheta, our Chairman Scientific Committee, to organize such a wonderful webinar. Dr. Devasmita Maji, who acted as moderator, Dr. Sweta Kriti, and Dr. Suma, who were the expert panels. My special thanks to our guest speakers, Dr. Sumita Ma'am, Professor Dr. Pradeep Sama, and our own Dr. Vivek, who have discussed the strabismus in length and in such details. I was listening fully, being a retina specialist also. I also learned from this, and I hope all our members must have thoroughly learned from the session. So my heartfelt thanks to all of you. And last but not the least, the platform provider Entoad, so that we can continue with this kind of webinars. Thank you all.
Thank you. Thank you.
Thank you, sir. Thank you.
Thank you, sir.
Thank you all.
Thank you. Thank you, everyone. Good night.
Thank
Good
you.
night. Good
Thank
night.
you so much for inviting me.
Thank you. Thank you.
Thank you.
Thank
Right.
you.
Yeah, because it was a learning for even the panelists and
Yes.
speakers. Dr. Sharma's talk, as usual, was excellent.
We all learned from all the talks, actually. It was wonderful.
Dr. Pradeep, I learned one new thing, the SR recession and splitting it into a Y for DVD is something really great. I'll go and try it.
Yeah, this is a unique procedure which was told to me by Dr. Borgen from Germany. And I tried it, it works. Yeah.
Yeah, that's great. Thank you.
So,
Good night, all. Good
thank you
night.
and Jai Jagannath.
Jai Jagannath.
Jai
Thank you,
Jagannath.
sir.
Okay, bye-bye.